expectation. So what is collateral damage in spine? The paraspinal muscles, interspinous ligaments, supraspinous ligaments, lamina and facets are the main things which gives the collateral damage and also maintain the sagittal balance. So any damage to these procedures, these ligaments will cause collateral damage. This is normally of a post-operative MRI for regular open conventional laminectomy. You see one level and one level down, lot of muscle damage, muscle atrophy, loss of facet joints and multiple things. So you know how things have started. It started with open technique, then mini open, then tubular, then endoscopic assist. So ultimately there is a constant quest to avoid this collateral damage. That started with use of surgical loops, microscope, endoscopic assisted. These are the scars of open surgery, mini open and microscopic surgery, and endoscopic surgery. So what is true endoscopic surgery? A incision of less than 1 centimeter, no muscle cutting but only muscle splitting, so almost no post-operative pain. Preserves supraspinous and interspinous ligaments, which are important for sagittal balance. So you just feel the cranial lamina and go down and go into the interlaminar window is interlaminar surgery. So as I told yesterday, there is only two routes of endoscopic spine surgery. One is the interlaminar route or a stenosis route. It can be uniportal or biportal. The other is a transforaminal route. Indications, I think you have seen most of the indications are taken up nowadays. So why endoscopy is ahead compared to other techniques? Because it has better visualization. You can look into all the corners where sometimes it's difficult using a microscope. You can go to the shoulder, you can go to the axilla, you can go to the other part of the traversing to the opposite side. So you can achieve very good, complete decompression. The traversing exiting into the foramen. And of course, a small scar. And definitely minimal surgical footprint. This is the post-op MRI of a patient who has undergone L4, L5 discectomy. It's normal laminectomy scar. You can see it's just minimal. You can see there is no much destruction of the facets or lamina. The multifidus muscle is thick and fine. So these are various papers why we should accept that endoscopic spine surgery is going to be not the future but the present need. This was the classification by the EndoSpine, but as Dr. Lim said, the classification is little wrong. But still they have given full endoscopic approach for multiple levels. So like anterior, posterior, transforaminal, interlaminar, but it's accepted. So you know how evidence-based medicine comes. It comes with expert opinion, case reports, case control studies, cohort studies, and our RCTs. Then we have RCTs go into meta-analysis and then becomes a gold standard. This is one more paper which says endoscopic spine surgery is the next gold standard management of lumbar disc disease. You can see there is a skyrocketing of papers from past 6 years. It has picked up so well. There are around 400 to 500 papers coming every year in endoscopic spine surgery. This is the AI-derived algorithm to show the advantage of 16 around 86 papers, which shows the benefit. Shows that endoscopic discectomy is more comparatively better than microdiscectomy. I mean a true microdiscectomy means by using tubes. The VAS score for back pain is comparatively more post-operative, And your ODI follow-up, final follow-up of endoscopic discectomy is very good compared to microdiscectomy. The duration of surgery is surprisingly fast once the learning curve is achieved. The length of hospital stay is very less. So the superiority factors for functional outcomes was very good. The duration of surgery was low. The length of the hospital stay was low. So again, not so inferior things or which is almost similar is still like a microscope with a good technique. One is a recurrence or reoperations, the return to work period. But I feel return to work period also is more better than endoscopic spine surgery. This is one more paper which shows that lumbar disc herniation is a good, and PSL is a good endoscopic technique. So it's a paper which has come down shows that the research, the trending research is endoscopic spine surgery. So you can see the number of papers skyrocketing from 2018-16, around 400 papers per month. These are the top 5 countries which are publishing papers. China is publishing the highest number of papers, around 402 papers in a single year. Next comes South Korea. India is little lacking in publications. So now I want to talk about the other special indications of endoscopic T-leaf or the most successful fusion in the history of normal spine surgery. Though many fusions have come down, like started with P-leaf, then with T-leaf, then O-leaf have come. O-leaf, two types. One is psoas sparing O-leaf that is called OLLF, which Varun sir, Bhupesh will talk about. The other is psoas, below psoas surgery like a true O-leaf, then X-leaf, then extreme leaf, multiple things have come. But I feel most of the listhesis, when there is progressive listhesis, it is a foraminal pathology. It will compress the exiting nerve. So I feel if you are doing fusion, if you are trying to do a fusion, it is better to decompress the traversing root and also the exiting root, then put a cage, which is very much possible with a regular T-leaf. So T-leaf is the most standard technique to know for doing fusions in any kind of spine surgery. Means in the 20 years, the most successfully done procedures is with endo T-leaf. So indications, yeah, of course, lumbar foraminal stenosis with segmental instability, lumbar disc herniation with segmental instability. So segmental instability we speak so much because if it is only grade 1 listhesis with no progressing listhesis, it's only foraminal decompression we can do it because we are not destroying much of the bones. But only for me nowadays my indications for T-leaf is with functionally active back pain or else again with functional back pain. So initial contraindications for severe disc space narrowing more than grade 3, grade 4, may as grade 3. As Dr. Lim was saying, now we are able to do it by doing bilateral fasciectomy, so the spine listens for what way you want to get it. So these are the specialized instruments where the instrument are gone in a reverse cocking fashion. So even the bigger paddles, bigger disc raspers, bigger instruments, bigger dummy cages, all the stuff are tucked in from outside the scope and they can be used. I think these things have been seen by Kaushal and all recently or done. So of course when you are trying to do new techniques, minimally invasive like laparoscopic surgery, you need to have good armamentarium. The armamentarium is the key for developing to do new techniques. So this is called a Kegel sleeve. This is a sleeve which is very bigger, which is around 18 to 20 mm sleeve. So once you finish the facet knockoff with a regular sleeve, you can put this sleeve and through the sleeve you can attach the cage and you can push in with a very big cage. So you can see we can insert cage up to 16 to 18. So and the lotto angle of 4 to 10 degrees. And nowadays expandable cages are also available. There are cages which go 6 sizes up, like 8 to 14 and 12 to 20. So this is one more funnel which is required to pack in, as a server showing how you pack the autograft taken. We get en bloc facet resection. That facets can be taken with use of a chisel or a drill. So even we follow something called en bloc. We remove the complete IAP, parts, and the laminate together. So we get a good chunk, almost you can expect around minimum is 8 to 15 grams of bone autograft. So which is very good enough. You don't need again autograft from which is going to be a costly fraud. You don't need BMD or osteogenesis, new things, or a bone graft from posterior relaxed spine. So this is how the patterns going through the scope, under visualization, passing through the nerve root, and we prepare the end plate. Why it is ahead? Endoscopic fusions are ahead, whether biportal way or monoportal way. It is ahead because of the good end plates. So if the end plates are well prepared, you can see the ALL, you are seeing the complete ipsilateral end plate preparation. You are also seeing the contralateral also, you can go reach. So you can prepare a very big fusion bed, which means very good fusion rate, which means the patients will get back to work period very fast. So compared to MIS TLIF, the success of endo TLIF is good because of two reasons. One is good endoscopic end plate preparation. Next, there is a good study done by Dr. Osman who started doing trans-Cammings fusion. So they found out that if the end plates are covered by 30% for fusion, that is enough for fusion. It doesn't mean you need to have 100% fusion bed. So which the Western world has cheated us, saying that putting a X leaf or putting a leaf is good because it has 100% fusion bed. I feel it is not much required. In P-leaf, the cage goes more straighter, so I feel the contralateral side it starts bending. So if you want to do P-leaf, you need to put to both sides cage. But if you are transversing the cage in like T-leaf, a single cage is good enough to go and take the complete load in the anterior lordosis. So you push the cage anteriorly, it takes up the complete anterior lordosis and it is center of the spine that it takes care of the fusion. So these are various cases where we have done fusion. You can see under vision. So the skin system is definitely lower, and the one more advantage of endoscopic TLIF is we don't take a separate incision. For example, you are using incision for taking a MIS screw. The right side pedicle screw, if you are trying to put on a cage, the same pedicle screw incision, you take a strap, put your dilator on the spinal lamellar junction, you do decompression, you remove facet, you do bilateral decompression, you remove the facetectomy. From the same direction you prepare the end plates from the upper screw, and also from the same direction you put the cage, and you finish putting the cage, you can use the same incision to put the screws. So it is only four cuts on the spine. These are a few cases of my cases of endoscopic fusion. You can see the cage is centrally placed. You may feel the cage looks big, small, but see the fusion. I hope you can appreciate the fusion of bone very clearly seen in the anterior lordosis. You can see the white thing appearing, it's a new callus formation. So these are the special instruments which are required for endoscopic fusion. These are the raspers, these are the dummies. So you can also check down whether your cage is going to snug in or not. And you don't need to oversize it. Once the cage snugs in, it is more enough for you to do fusion. So you can see in the other side, the one-off fusion, the cage is very well centrally placed, and the direction of cage is perfect, and the turn is also very good. So this is an endoscopic cage glider. We call it an endoscopic cage glider or an endoscopic screwdriver. So this instrument helps you. It's not costly. It's maybe around 400 rupees. The only problem is the tip. So each company of cage has their own beading. So if you are using Jesco, you take your Jesco cage, get your tip done. So you put this one through the scope, and you can fix the cage and use the Kegel sling. Under visualization, you can nicely insert the cage. You can see the traversing route. You can see the fat of the exiting nerve root. So the typical Cammings triangle fusion with over the top decompression. This is a recurrence case. It has patient 2 times recurrence, so we have fused the end plates. So both bilateral decompression and Cammings decompression with TLIF is very much possible with this technique. So these are the few various cases. You see the cage looks small, but the cage is centrally placed. So it definitely takes up the load. So we can achieve good, even males grade 3 also, we can achieve good amount of sagittal correction, and also the foraminal length is well maintained with good cage. So patients can, and also there is direct decompression of the exiting nerve root. So I feel this is a gold standard for your endo fusion. So this fusion is almost similar or same like UVE. So UVE and monoportal fusion, the technique is same. It is just T-leaf, knock off the facet, decompress the exiting nerve in the traversing nerve root, prepare the end plates and fuse it. So as I told you, this is the learning curve of my cases. Started with a regular, this is how you should select when you start doing monoportal surgery. So start with regular one-sided disc prolapse. You can see the traversing nerve root, you can see the big disc bulge. This is a special instrument we designed, it's called an endo knife. Most of the people don't use it, but I use it for opening the annulus. Start with wide laminar window, no much bone required cases, just do decompression. You can see the traversing root is free and fine. So I have done only partial flarectomy, as one of my friend from Delhi Max was asking. This is the thing I do, sir. You asked me that you need to remove complete phlegm of all the cases. No, only for discectomy. Sometimes I do only partial ipsilateral flarectomy, see the edge of the root and start doing it. So next case is, of course, canal stenosis. Canal stenosis by endoscopic spine surgery is good because you start drilling the cranial lamina to the edge of the flavum. So somebody was asking in the morning, once the edge of the flavum is deep in the cranial lamina is achieved, the advantage of endoscopic spine surgery is the irrigation. The irrigation itself is a helpful tool to dissect the additions of the dura down to the cord. So this will prevent your chance of dural tear to almost 80 to 95%. So you are seeing the same video. So we have achieved, it is a case of central disc prolapse. Initially, central disc prolapse was considered a tough job because you have a track of the traversing, even in open surgery. Because you have a track on the traversing root side, you enter the disc space and the track is same, your instruments just go in and come out. But you can see the preoperative MRI and the post-op MRI, the central disc is well removed. That means that versatility of the disc inclination for doing discectomy is very much possible with the endoscope. This is one more technique of mine, it's called as the other potent technique. So when I want to do bilateral discectomy, I don't use multiple ports. I just put one more instrument from the opposite side and remove the discectomy. So even if you have a tight canal, you have the facet tropism is straight. So you tend to destroy the facets. As sir was talking about contralateral discectomy, you can use this channel. I don't do contralateral, I put ipsilateral, see the nerve root and send the instrument so that I don't destroy or injure the neural structures. So obesity is the favorite indication of endoscopic spine surgery. So the surgery becomes, because of tunnel vision in open surgery, it becomes too tough. So this is a short woman who is around 125 kilos. That's what is the problem, because we do a good laminar spatial defect, decompress the nerve root very well. You can see the inflamed nerve root, you can see the discectomy scar, you can see the opposite side. The patient had symptomatic right-sided, so we are going to right side. So severe canal stenosis, the advantage is that we are going to have something called a bird's eye view. What do you mean by bird's eye view? This is the view which helps to decompress both the roots, and you know this concept. What's the flavum ends? The flavum end means there is no compression. So you can see the ipsilateral traversing root is free. The disc space is calcified, so we are not worried about it. And see, this is what we call it a bird's eye view. This is what you see in a conventional laminectomy that you feel it is a complete decompression. So bird's eye view is very much needed for complete decompression. So if I have two levels of stenosis, we do something called, Dr. Lim does something called jumping technique. Sometimes I feel I jump too much, so I miss the level. So I just walk over the lamina and go to the other space. So there is L4, L5 space, the decompression has been done. I just walked over the lamina, kept it intact, didn't destroy it, and entered the upper space. So 2 level, walking over the lamina, 3 up to 3 level, you can do bilateral decompression. You can see that's the dural conditions. Bilateral decompression with a single incision. A single port bilateral decompression up to 3 levels can be done. So this is again, then once your expertise of stenosis and disc herniations have reached to a good level, fusion is not a difficult thing. So even grade 3, grade 4 listhesis, we can achieve good fusion with good sagittal balance correction just by knocking off the facet. The advantage is good functional outcomes. Patient is walking immediately after the surgery. This is the cage placement. I'll show on why it is. So this is one more video. You can see the L5 root, that is the external root in the L5S1, and you see the S1 root. So both the Camel's triangle is completely decayed. You can see below is the cage. So it's an ideal T-leaf. It has been, the S1 has been decompressed and the external root of the L5S1 has also been taken care of. So it implies the facet has been completely knocked off, the up to the parts has been removed. So my perception of cervical spine surgery has been completely changed after endoscopic spine surgery. We have a talk tomorrow by Dr. Lim. So initially my selection of cases were only laminar foraminectomies and only lateral discs. Now even CSM means cervical spondylotic myelopathy, we are trying to do decompressions and achieving similar goals. So endoscopic discectomy is very good, very clean, and a clear direct decompression of the foramen compared to ACDF. Because ACDF, the risk is more of you have some risk called extended segment degeneration, and sometimes it's a foraminal stenosis. You need to break the oncovertebral joints, which is very bleeding technique. So I feel an oncovertebral joint breaking is still is not a direct decompression. You just feel the click of breaking of oncovertebral joint, you feel you have achieved decompression. But here you are going to decompress the nerve. Why decompressing the nerve is very important is because the cervical root, the dorsal side has a sensory aspect, the ventral side has a motor aspect. That is why patients having a surgery, this technique was told by Dr. Lim to me. That's why in post-ACDF, the motor aspects improve, but still patients complain of numbness. Because you need to always decompress the dorsal and the ventral aspect of the nerve root. The dorsal and the ventral. The dorsal decreases the sensory, the numbness. The ventral, where the disc herniation is giving compression, decreases the pain. So, or the motor aspect. So, decompressing the both sides of the nerve root will give this edge. In cervical spondylotic myelopathy, already patient has gone extended segment degeneration and asked on 2-level ACDF. We started doing up to 3-level cervical laminectomy with single incision. This is from C3 to C6 laminectomy with a single port. Safely achieved both. It is a spinous, it's a floating, it's kind of floating laminoplasty. The spinous process base is removed, but the spinous process is left over. So, but bilateral decompression, I think you can see it is well achieved. And even the boosting effect of the cord has been gone. So, in focal segmental stenosis or 2-level segmental stenosis, I feel endoscopic spine surgery is going to be far ahead. The future, the concept which is given by the Japanese, the anterior pathology should be from the anterior, posterior is from the posterior, is going to change off. So people with OPLL, they still do the anterior corpectomies and anterior release and all this stuff, which is considered to be ending with dire complications. Posterior cervical decompressions are picking up very well. Posterior laminoplasties, endoscopic laminoplasty is also coming up. So even up to 4-level CVJ, I think we talked in the morning. So most of the cervical pathologies can be well addressed, including the foraminal stenosis. The advantage is you don't need to put lateral mass screws if your patient is also having CSM with brachialgia, because here we are not destroying the facets. So which side you need to have foraminal decompression, you can decompress it and just be happy, don't need to fuse it. Because as Dr. Alex was talking about it, He is doing the biggest study in PECF. The even end block removal SAP or end block removal of facet in cervical pathologies is not a problem for progression of the recesses. And of course, coming to complications, it is discitis. Yes, of course, these complications should be avoided by the good OT preparation, good pre-operative assessment, and still discitis is a nightmare for everyone. It tends to happen sometimes. So as we are having good techniques, now we can do endoscopic lavage of the disc plates, but I always do something called fuse the spine. Micro instability is less, patient comfortably walks back, let the antibiotics work, he'll be fine. The worst other complication is one dural tear which has happened. The problem is I didn't expect the dural tear which was visible to me. Patient come back for follow-up to, because you can see the decompression is so adequate, patient is fantabulously doing fine, but he has come down complaining of small headache and a small knob in the back. So we did MRI, there is a pseudomeningocele. So again the technique is the same. You just go, dive in, start from the good new neurostructure area. Then the other neurostructure is just fibrosis. Just remove the fibrotic tissue and put a glue. In India we don't have tacocele, we have something called Duragen. Duragen little swollen up in the irrigation, but still it works well. There is also bovine collagen graft, not very costly. Once you pick up endoscopic spine surgery as your personal entity, you can get it for 35-40,000, but it will come for around 8 to 10 cases if required. You can just cut a small piece, it gets not swollen up. I have a video tomorrow, we do something called inlay grafting. Outlay grafting is also accepted, but there is something called inlay. Inlay, the advantage is more successful and it is more water sealant. So personal experience among, this is just a personal experience of few cases what I have done. Among 1,000 cases, we have finished more than 3,000, but most of the cases, we have L4, L4, L5S1 and the cervical infusions. So I feel the recurrence rate is only comparatively less than 0.4%. And the dural tear is only for 3 cases. 2 cases didn't require revision, 1 case required revision. And I had only 1 case of discitis after monoportal surgery. I had a lot in transforaminal surgery, but in monoportal surgery, no. I have only 1 case. I managed with fusing it. Any questions?